Hi students, I am Dr. Sidharth Sethi and today I'll be discussing with you the INICET May 2022 Pediatrics questions. So before I go forward, I'll like to talk to you about an analysis of the pediatrics aspect of this exam, and I feel that the topics of the exam were all repeated from the previous exam questions. So all of you, like I always tell you in your classes, that even though questions are not repeated, topics are always repeated. So you will have the same old topics, whether it's neonatology, whether it's neurology or nephrology. So these are the simple topics which will always be repeated. So you need to be strong in those specific areas. There were at least 10 questions from pediatrics and I'll be discussing those. So first question is a repeat question from previous NEETPG question, NEET 2020, and it's a boy with recurrent bloody stools, atopic dermatitis and thrombocytopenia. So it's a clear-cut triad of atopic dermatitis, bloody stools, thrombocytopenia. You should be thinking about an X-linked recessive disorder called Wiskott-Eldridge syndrome. So it clearly looks like eczema, atopic dermatitis. So today what I'll do is I will be talking to you with reference to all important textbooks. I'll be giving you references from all the important textbooks. So remember, according to the Nelson's textbook, Wiskott-Eldridge is X-linked recessive disorder with atopic dermatitis, thrombocytopenia and normal looking megakaryocytes, but these are small defective platelets. So remember, these platelets are small defective and they have immunodeficiency as well. So these children have immunodeficiency. It's a disorder. It's a mutation in the gene called WASP, Wiskott-Eldridge syndrome protein gene, okay, which controls the actin filaments in a body for the cell migration. That's not important, but remember the WASP gene. Now, this clinical history is also very classic. And as you can see that the most common presentation of Wiskott-Eldridge is bloody stools during infancy and prolonged bleeding. So in fact, many students told me that this was a 11-month-old baby. So classically, bloody stools during infancy. Remember, thrombocytopenia is not because of antiplatelet antibodies. So this option is out. They have atopic dermatitis, recurrent infections. Now remember, I would like you to remember one more important point about Wiskott-Eldridge. And the point is that they have low IgM. Remember, they have low IgM, elevated IgA, IgE, and normal or slightly low IgG. Okay, low IgM, elevated IgA, IgE, and a normal or slightly low IgG. So coming back, this does not look like a malignancy to us. It clearly looks like X-linked recessive Wiskott-Eldridge syndrome with a classic presentation. Now here's a question on neonatology. What is the best alternative to mother's milk in a low birth weight? And students, I have been telling you in all of your classes about a section on feeding of low birth weight. So whenever we talk about neonatology, we talk about feeding in low birth weight. So do refer to that section. And today I'll be talking about the Ames Nico protocol. So 2019 Ames brought up a very nice book on Ames Nico protocols. And in all of my classes, I talk about these Nico protocols. Now look at this sentence. All low birth weight infants should only get breast milk. Only get breast milk. Okay, by Pallade or tube, either you give mother's or donor milk. So there is no doubt about it. Breast milk is the best, mother or donor. Now, since we are talking about express breast milk, all of you please remember, according to the Ames protocols, express breast milk can be stored for 6 hours at room temperature and 24 hours in refrigerator. Okay, 6 hours at room temperature, 24 hours in refrigerator. Okay, now, so we said human milk. Now, if human milk is not available, then you go to formula feed. So remember, human milk, mother, followed by donor, followed by, if it's a preterm baby, you give preterm formula. If it's a term baby, more than 1500 gram, you give a term formula. And lastly, cow milk. Cow milk is right in the end. So there is no doubt the answer to this question is a human donor breast milk. Let's take you to the further. ACTH is the drug of choice for, and in every class of yours, and even in DVT, every DVT since last many years, I always talk about epilepsy and what Nelson's textbook tells you. So this is one of a screenshot from my eMedicoz lecture where I was talking about uh, infantile spasms and West syndrome. Remember, West syndrome is a triad of infantile spasms, mental retardation, and the classic EEG, which is called Hips arrhythmia. So remember, in infantile spasms, there is a classic EEG called Hips arrhythmia. It's a chaotic, high voltage, generalized slow wave. So these are chaotic, high voltage, generalized slow waves. The drug of choice for infantile spasms is ACTH. Only for tuberous sclerosis, the drug of choice is vigabatrin, only for tuberous sclerosis. Okay, so let us just revise what the current issue of Nelson's textbook talks about. Remember, the drug of choice for absence seizures is ethosuximide. Focal epilepsy in children is oxcarbamazepine. Generalized seizures in children, levetiracetam. Okay. Infantile spasms, remember ACTH, but if you have infantile spasms with tuberous sclerosis, we give vigabatrin. And for juvenile myoclonic epilepsy, now the current issue of Nelson's textbook says levetiracetam. Okay. So the answer to this question is of West syndrome or infantile spasms is ACTH. If they are asked about tuberous sclerosis, then vigabatrin. And I told you for JME, it's levetiracetam. Now, neonatology is very important for your exams because your examiners are neonatologists. Okay. So, I always talk about neonatal resuscitation, and I would refer you to a very nice module in eMedicoz on emergencies. And in every class we talk about resuscitation, and we always talk about that the best indicator, once you start bag and mask ventilation, you should look at improvement in the heart rate. So remember, the best indicator of adequacy of ventilation is improvement in the heart rate. And this is one of the screenshots from my class, that if heart rate is not improving, then look at ventilation corrective steps. And the mnemonic is Mr. SOPA. Okay, so if heart rate is not improving, you do some ventilation corrective steps, and the mnemonic is Mr. SOPA. M stands for adjust your mask and the seal. R is reposition the neck. S is suction the mouth followed by nose. O is open the mouth and lift the jaw forward. P is you may increase the pressure of your mask in the increments of 5 to 10 centimeters of water. Okay, so increase the pressure of your mask in increments of 5 to 10 centimeters of water. And lastly, if nothing is improving, please change the airway. You may go for an endotracheal intubation or a laryngeal mask airway. So the answer to this question was clearly improvement in heart rate. Now, which amino acid does not read restriction in maple syrup urinary disease? Now, as you know, MSUD is a problem of the branch chain amino acids. So according to the Nelson's textbook, our branch chain amino acids, which are leucine, isoleucine, and valine, they need decarboxylation, which is by an enzyme which uses thiamine as well. Okay, so remember, decarboxylation of these branch chain amino acids is by an enzyme which needs thiamine. Okay, so abnormality of these decarboxylation and these enzymes leads to maple syrup urinary disease. Okay, so these children may come to you with unexplained coma, infants with unexplained coma. Okay, so we diagnose MSUD by looking at these branch chain amino acids. Remember, you should also remember the DNPH test. In PGs, we used to remember the DNPH, and even in your MBBS. So what you do is you put few drops of DNPH, 2,4-dinitrophenylhydrazine, to the urine, and a yellow precipitate is seen in MSUD. Okay, so the treatment is restriction of valine, leucine, and isoleucine. Thiamine because thiamine is needed in these enzymes. And when these children come to us in coma and refractory acidosis, we do dialysis, peritoneal or hemodialysis. Okay, so diet, thiamine and dialysis. Now here is a question on vaccination. Every exam, last time they talked about the current IIP vaccination schedule of 10 years of life. Now this time they asked, if a child comes to you after 6 weeks, he has got DPT. Now he has come to you at 1 year of life. What should be the next step? Should we repeat the course? There is no need for DPT, give a second dose. So students, according to the Indian Academy of Pediatrics, now I'm a fellow of Indian Academy of Pediatrics as well. So there's a book by Indian Academy of Pediatrics, and I'll give you a very nice reference which talks about catch-up immunization. If you have missed the immunization, it does not need restarting the entire series. Okay, so and listen to me carefully. If a dose of DPT, inactivated polio, Hib, pneumococcus, hepatitis A, MMR, hepatitis B, HPV, varicella is missed, subsequent immunization should be given at the next visit as if the usual interval has elapsed. Okay, so remember, you need to continue the vaccination. You need to give the second dose now. Okay, so here you will give the second dose. You don't need to, so because these are anyway booster vaccines, they boost the immune response. So you will give the second dose here. Now, which is an X-linked dominant disorder? In fact, there were 2 questions in this INICET. Now, remember that the most important question here is, and the most commonly, without any controversy, Rett syndrome is X-linked dominant. So there is no doubt about this. Rett syndrome is X-linked dominant. Okay. The other disorders which are X-linked dominant are hypophosphatemic rickets, inconsentia, pigmenti, and Aicardi syndrome. In X-linked dominant disorders, these are dominant, so all generations are affected. In X-linked dominant, affected father gives the disease to all daughters. Affected father gives the disease to all daughters. Look at any affected father. That's how we identify. Affected father gives the disease to all daughters and none of his sons. There is no father to son transmission. Okay, and Rett syndrome is lethal in male fetuses, so only females survive. So there was another question in this INICET, and many students told me there was a question on which disorder is only seen in females, Rett syndrome. So the answer to this question is Rett's. Remember, OTC is controversial. It is X-linked recessive in most of the textbooks. So this is controversial, but Rett's is surely X-linked dominant. SMA is X-linked. SMA is, and we'll talk about SMA today, it is autosomal recessive. Duchenne's is X-linked recessive. Now another question which is a favorite question of your examiners, and every NEET and INICET will have a question, and the question is on congenital absence of seminal vesicles and vas deferens. Now I have been telling you in each of my classes, this is one of a screenshot of my regular class where I told you that in cystic fibrosis, all males have azoospermia and they have absent vas deferens. So they are infertile. Okay. So remember, according to the Nelson's textbook, 95% of males with cystic fibrosis have absent or obliterated epididymis, body and tail, vas deferens and seminal vesicles. So the question was absent vas deferens and seminal vesicles are present in cystic fibrosis. Now Nelson's textbook also says that all males with cystic fibrosis are azoospermic because of failure of development of the Wolffian structures. Okay, sexual function is not impaired, but they are azoospermic. Females, remember, now they may ask you about females. Now female fertility rate is also reduced because of poor nutrition and advanced lung disease. They may also have more mucus in the cervical glands. Now please do read about this. I can tell you in the last year NEETPG, there was a lot of concentration on that in cystic fibrosis they have hyponatremic, hypochloremic, metabolic alkalosis. So remember, hyponatremic, hypochloremic. And It persists throughout life. Then in the last year NEETPG, there was a question that these children, when they grow, they may have DIOS, distal intestinal obstruction syndrome. And as you can see here, in adolescent and adulthood, you have a CBAVD. What is CBAVD? It's congenital bilateral absence of the vas deferens. So please look at this table, this algorithm, and how cystic fibrosis affects children as they grow. So there's no doubt about this. This question, the answer to this question was cystic fibrosis. Now the next question was on tongue fasciculations. Of course, all of you know fasciculations are seen in lower motor neuron weakness. Now myasthenia gravis is a problem of neuromuscular junction. Duchenne's is a muscular problem. This is a neuropathy. Now spinal muscular atrophy is a disorder of spinal motor neuron. It's a disorder of spinal motor neuron. So these children are floppy. They are floppy. They have hypotonia. They are in a frog-like posture. Okay. So they have lower motor neuron weakness. So atrophy, hypotonia, and fasciculations. So you can appreciate fasciculations of the tongue in spinal motor neuron weakness or spinal muscular atrophy. We diagnose it by homozygous deletion of the SMN1 gene. Okay. Remember, this is a very important topic. Read about the new gene therapies in SMA, and this will also come in your exam because this is the in thing right now in the world. The costliest drug in the world is now the gene therapy for spinal muscular atrophy. Now there was a question on a child comes to you with hypocalcemia and absent thymus, and this photograph was there. Now this is a problem of which structure? Now all of you please see here, these are the pharyngeal arches, these are the pouch, first, second, third and fourth, and these are the clefts. Okay, I'll just try to zoom it for you. So these are the clefts. Now what you can see here is that the pouch, this patient has hypoparathyroidism and absent thymus. So remember, thymus comes from superior and inferior. So thymus is from the third pharyngeal pouch and inferior from third, superior from fourth. So remember, this is a problem of this C and D, C structure here. So third and fourth pharyngeal pouches, okay, which is called the D-George syndrome. So this child has the classic D-George syndrome, which is also called the velocardiofacial syndrome. 22q11 deletion. Remember, it is 22q11 deletion. Now your examiners may also ask you which cardiac anomalies are seen in D-George syndrome. Remember, D-George syndrome is abnormality of third and fourth pharyngeal pouch. Okay, and they also have conotruncal anomalies of the heart. So remember, the most common anomalies of the heart are conotruncal anomalies of the heart. So the answer is C here, third and fourth pharyngeal pouch. Then they showed you a child with fatigue, joint pains, and they showed you a rash of his metacarpal joints and fingers. What is your diagnosis? This is a classic case of juvenile dermatomyositis. Remember, according to the Nelson's textbook, juvenile dermatomyositis is the most common inflammatory myositis in children. It's the most common inflammatory myositis in children. They have proximal muscle weakness and the classic rash. Now, the diagnostic criteria for juvenile dermatomyositis are the classic rash. Number one, they have a heliotrope rash of the eyelids. You can see here a child with heliotrope rash on the nose, on the face and the eyelids. And today we showed you the Gottron's papules over the metacarpals, okay, over the back of the hands. So this is the classic rash. Now plus three of the following, any three: weakness, which can be symmetric, proximal. Now remember, they may have the Gower sign. Now, so remember, Gower sign is not specific for Duchenne's. It can be seen in dermatomyositis as well. And this question has come in your exam multiple times. So in fact, in your past Ames exams, they had a child with elevated CPK, and a rash with Gower sign. So you should think about dermatomyositis as well. So muscle enzyme elevation, characteristic EMG changes of dermatomyositis, which include fibrillations, positive sharp waves, and short polyphasic motor unit potentials. And the classic muscle biopsy. Here what you can see is necrosis of the muscle, inflammation, and necrosis of the muscle fibers. Okay, so the classic muscle biopsy. So you may have any three of them to call it as dermatomyositis. The drug of choice is steroids and methotrexate. So you may also use methotrexate in some of these patients. So this child has a classic case of Gottron's papules of juvenile dermatomyositis. Now here is a child, they asked you in your exam on a child who was around 100 centimeters tall and creatinine of 1. Calculate the estimated GFR. And as I told you, your examiners are mostly neonatologists and pediatric nephrologists. So they like to talk about the Schwartz formula. Now remember all of you the Schwartz formula. Dr. Schwartz is a pediatric nephrologist. I'm also a pediatric nephrologist. He's in Rochester, America. So he gave this formula many years back that you can estimate the GFR by a formula. K is a constant multiplied by height in centimeters divided by serum creatinine in milligrams per deciliter. Now K, if you are estimating creatinine by the old Jaffe's reaction between 2 to 12 years, the K is 0.55. So there was an old Jaffe's reaction in which the K was 0.55. So this was the first K which Dr. Schwartz gave. Now if you use this reaction, we used to overestimate the GFR. So हम गलत GFR estimate करते थे. Now I would say maybe Ames examiners would have told you that this creatinine within the brackets measured by enzymatic method. So they should ideally tell you measured by enzymatic method. Now all of us have switched on to measuring creatinine by enzymatic assay. And now the K is 0.413. So 0.413 multiplied by 100 is 41.3. So the answer here is 40 ml per minute per 1.73 meter square. So remember now Dr. Schwartz has given a new K of 40. So it is 0.413. Okay, so this is what we follow every day of my life. This is what I do and tell the parents how much their child's kidney is functioning. Now there was another question on which drug is not used in sickle cell anemia patients, and I'll give you the reference from the Nelson's textbook. Remember, according to the Nelson's textbook, hydroxyurea is a very important drug for sickle cell anemia. Hydroxyurea reduces the frequency of pain episodes, hospitalizations, and blood transfusion. Okay, so Nelson says that every patient of sickle cell anemia more than 9 months should get hydroxyurea. Simple. Now Nelson's textbook also says that now they have FDA, the US FDA has also approved L-glutamine as an add-on agent to children more than 5 years. So children more than 5 years, they add on glutamine to hydroxyurea. Okay. Now there are many new drugs in sickle cell anemia. There are just 2 more new drugs which you should know. Another drug which acts on the hypoxic, the HIF factor, voxelotor. And now this is approved for children more than 4 years who are still symptomatic despite hydroxyurea. There's another drug called crizanlizumab, which is also approved for children more than 16 years. Okay. So remember this bebtelovimab, this drug is actually a drug for COVID. Okay. So this is a new monoclonal antibody for COVID-19, and this monoclonal antibody in fact also works in the Omicron variant. Okay. And remember that this is given in high risk patients, okay, who get COVID-19. Okay, so that was all about the INICET pediatrics questions, and I have given you all the essential references, all the essential text which you need to know before you go for your NEETPG and INICET. So remember, these topics also come in your NEETPG exam, so you should be reading and revising these videos before you go for your exam. This is me, Dr. Sidharth Sethi. Thank you. All the best.